Um, First of all, I just want to say thank you all for joining us. If you were here last time, thanks for coming back. And if this is your first time, we're glad to have you at this second session of the maternal health and primary care, where we will be talking about, well, I should say Christina will be talking about the second trimester. So just a few things we want to make sure you're aware of. We are recording this session and we will share it after the session is done. We will also be sending the slides via email, so you'll have that in the follow-up email that gets sent. We do have everybody muted at this point, but you are welcome to use the chat or unmute yourself to ask questions at any time during the Q&A portion that we'll have at the end of this session. We do have CEs available for this series through Weitzman Institute. And in order to claim the credits, you will need to create an account or log into your Weitzman account on their CE platform and complete the post-session evaluation. And this can be done for each session, and you can get up to 4 credits total. And that information is also being sent in the follow-up email as well. So you'll get that information there. So I do want to go ahead and introduce Christina, our speaker, Christina Carpenter. She is a physician's assistant with more than 20 years of experience in healthcare. She spent 16 years practicing outpatient obstetrics and gynecology before transitioning to her current role in gynecology at Penn State University in their health services area, where she's been for 4 years. In addition to her clinical work, she is pursuing her master's in healthcare administration at Penn State University, an academic path that helped inspire her involvement in this opportunity. And she's also been presenting this same seminar to members of the Pennsylvania Primary Care Association. So Christina, thank you for being here again, and we'll turn it over to you.
All right, thanks for having me, Alice. I am happy to see everybody back and everyone that is new. I had to get myself out of the chat because I was checking who it was here and what you all were doing. So I had to get out of there. I would have just read that the whole time. So, all right. So we are going to do second trimester prenatal care today. We did first trimester last time. Only makes sense to do second trimester this time. So you can move on to that next slide. Just as with my first presentation, this is my disclaimer. Please take note the day that you are viewing this presentation, the date, I should say. The medicine changes rapidly. We know this, right? And you want to be sure you're using the most up-to-date information. And if this is a little out of date, please make sure you check and make sure that it's correct still. Also, just as I said last time, we recommend that, or we recognize that these are the recommendations, but it's our job as clinicians to educate the patients. We live in these communities with these patients. We're familiar with some of their hurdles that they may be facing, and we understand that not all of these recommendations are going to be realistic. And so our goal and our job is to work with the patients and do what we can, right? We know what the recommendations are. We let the patients know, and we work with them and we make it work for everybody. All right. So on to that next slide. So we're going to get started with today's topic, which is prenatal care in the second trimester. This slide may look familiar. It was in the first one. Remember, second trimester is 14 weeks to 27 weeks and 6 days, or I should say up to 28 weeks, will be included in the second trimester. We'll go on to the next one here. Also probably or is a repeat from the last time. And we're talking about the second trimester. So our patients will be falling into that every 4-week category. ACOG, remember, is becoming very vocal about supporting tailored prenatal care. And so while most prenatal care providers have followed this traditional prenatal visit schedule, it does require a lot of effort and planning and cost for the patient. And really, there isn't clear evidence of benefit that it has to be exactly this way. And so ACOG released a clinical consensus May of 2025. It is in my references, and I do encourage you to look at it. It kind of breaks down their views on tailored prenatal care and what it might look like for you and for your patients. So feel free to check that out. All right, on to that next slide. So the second trimester is really unique, I feel. So if you think about where the patient is mentally when they come into this trimester, they're at 14 weeks. And then at the end, they're at 28 weeks, right? So their priorities and their thought processes are really changing during much of this trimester. They go from thinking about like, what is it going to feel like to feel my baby move? Worrying about the anatomy scan, to thinking about delivery and life after delivery. At 28 weeks, they're moving into that third trimester. So they really shift mentally a lot, no matter the age of your patient. But your really young patients, it's really amazing to see some of our teenage patients change during this trimester. They really grow up, for lack of a better word. And, you get to do that with them and kind of hold their hand through that and support them through that. Right. So those goals, we're going to offer genetic testing. We're going to do a fetal anatomy ultrasound if possible. We're going to look for gestational diabetes and anemia. We are going to, just like the first trimester, identify pregnancies that could be at increased risk for concerns, and then obviously always promotion in terms of health, smoking cessation, all of those things. So. Moving on to that next slide, common symptoms that you will hear about from patients in the first trimester. Not all of them are alarming, but to patients, they can be, really affect quality of life. And so they'll bring them up. So we're going to touch on these a little bit individually if you want to move on to that next slide. So remember, in early pregnancy, nausea and vomiting are caused by these rapidly increasing hormones like beta HCG, estrogen, progesterone, placental growth hormone, all this stuff. In someone with severe nausea and vomiting persisting beyond the first trimester, so we're into the second trimester, you should really be looking for other kind of non-obstetric causes. And after you've ruled those out, you can start to use some of the over-the-counter remedies and lifestyle changes, as well as pharmacotherapy that we actually discussed in the first trimester presentation. But most commonly, nausea, vomiting, you're going to see it between that 4 to 12 weeks of gestation, but some will go up to about the halfway point of the pregnancy, so 20 weeks. Make sure you're monitoring for significant weight loss, dehydration, pain, vaginal bleeding, all of the things, especially with vomitings, excessive vomiting. Sometimes they will stir up some bleeding as well. And, make sure you are ruling out things that are not as benign as nausea, vomiting to pregnancy, like molar pregnancy, hyperemesis, appendicitis, don't forget about it, and thyroid disease. And we'll move on to that next slide. And I just want to take a minute to put in a personal plug for hyperemesis. So this is not nausea, vomiting of pregnancy, as many of us may have thought of or learned in school. This is a condition that's accompanied by severe dehydration with usually an acid base and electrolyte abnormalities that can lead to many complications, including Wernicke's encephalopathy and death, right? That's rare, but it does happen. The complications extend beyond delivery. These patients can have gum and dental issues from the recurrence of the vomiting. They even can have severe nausea and vomiting that continues to occur after delivery around ovulation and around the time of their period. And this can certainly affect future family planning. Some patients with severe hyperemesis gravidarum will only have one child, or they will pursue some other way, adoption, surrogacy, something else to grow their family. So if you have a patient, even you're seeing them when they're not pregnant and this was in their history, please make sure you address it and understand that it does affect them well after delivery. Okay, so have it on your differential. A lot of times it is not formally diagnosed until the second trimester, which really may be too late. This is actually a first trimester problem. We need to be looking for it and we need to identify it. There is a pretty decent termination rate. There is also quite a bit of depression and suicidal ideation with hyperemesis gravidarum. It is all encompassing. Just imagine being just nauseated from the day you wake or the minute you wake up until the minute you go to sleep for 9 months. It's just unbearable. A lot of our data about hyperemesis comes out of the UK. Meta-analysis studies out of the UK provided this data that I'm showing you here. I post on here the HER Foundation. They are an amazing resource for patients and clinicians. They have a great website for clinicians that kind of walks you through this differential diagnosis, treatment protocols even. And so I asked that if you're kind of thinking like, this seems like more than nausea, vomiting, go to their site, utilize it. And at a minimum, I ask that you refer patients to the foundation's website. They have great support groups, which really support knowing that you're not the only one going through this, and just how debilitating it is, and that they're not making it up, because patients really do hear from social media and even from physicians sometimes that it's in their head, and they need that support. It's a really lonely place for patients to be. And if you're not being taken seriously, it can really be quite traumatic. Check in on these patients, advocate for them. As you can tell, this is very personal to me. I did have hyperemesis with my second pregnancy, and it was like nothing I've ever seen working in obstetrics. I had been in obstetrics at that point, 13 years, and had never seen something quite like this. I couldn't bathe myself. I couldn't stand. I couldn't drive for over 6 months. Literally sitting in a bathtub made me sick. The movement, I felt like I was on a boat. It was unbelievable. I lost my job over it. I would not have made it without my support system, which included my providers who took me seriously, and were not afraid to initiate medications, including a PICC line. TPN was considered, but thankfully I was able to get by without that. So do know that you can definitely see this, and you need to take it seriously, and please don't blow them off, because you may be the person who helps them survive, literally. Suicide rates are quite high. All right, so there's my plug on that one. We'll go on to the next slide. So off my soapbox, onto another common symptom in the second trimester of pregnancy, which is, acid reflux. You're going to see this quite a bit come about as well. Do make sure you're monitoring, just as you would in primary care in general, for atypical presentations, right? Are we looking at fevers? Are we looking at Murphy's sign, right? Or should we be thinking about the gallbladder? Is there anything else that we should be thinking about? Just don't, pigeonhole yourself into pregnancy-related acid reflux. Remember, though, there is a lot of like progesterone mediated lower esophageal like relaxation of the sphincter. And that's the biggest thing that plays into this. Patients get frustrated because they can't even drink water without getting symptoms. It has nothing to do with spicy food at this point, or eating too big of a meal, although those things are good to avoid. They drink water and they have reflux, and they get so frustrated. So make sure you look into the differential, and make sure that you rule out anything else, and don't just chalk it up to pregnancy. All right, we'll move on to treatment here. Obviously, conservative therapy first. Eating small, frequent meals, limiting caffeine, peppermint, chocolate, things like that. Antacids, including Tums, Rolaids, Maalox, Mylanta, these things can be used. Try to avoid using more than what the bottle recommends. Do remember to avoid things like Pepto-Bismol. That active ingredient acts kind of like aspirin, and sometimes associated with some birth defects and fetal cardiac issues. So just make sure, if you have a patient who's taking everything, try to get them to avoid Pepto if you can. Persistent symptoms, you can move on to a PPI if you need to. All right, next slide. So another common symptom as patients move into the second half of pregnancy, and these can really start to occur anytime, but most commonly it's the later part of the second trimester, sometimes sooner in patients who have had, that this is not their first baby. And this is musculoskeletal pain, right? Main reasons are this acute change in weight distribution, hormone changes that are allowing this musculoskeletal laxity, which is perfect for delivery. We want that pelvis to be lax and separate, but when that happens prematurely, it is really uncomfortable just to walk. And so, remember, it's part of the process, but it is quite uncomfortable for patients. Just as you would in general primary care, please make sure we remember that things like saddle anesthesia, weakness, numbness, urinary concerns, retention, incontinence, these are all things that we really need to be looking into anything more severe that's happening. Okay. All right. Moving on, in terms of pain management, or pain treatment, I should say, I strongly recommend having either a website that you refer to, or a pre-printed low back exercise brochure that you just have, because this is such a common thing that you're going to hand this out on the daily. Your facility may even have it available in their EMR if you have some like patient education material, but rest, heating pads for short periods of time on low are fine. Supportive devices like belly bands, patients have bought, Tylenol. Physical therapy is definitely used in pregnancy. Osteopathic manipulative treatment also used in pregnancy. But then again, those low back exercises that they can do at home are really, really helpful. But it's nice to give them somewhere like to go, whether it's a pamphlet or somewhere online that they can go to. All right, so on to that next common complaint in pregnancy. Headaches and migraines are very common in pregnancy, especially for those who had them prior to pregnancy. However, remember there are some red flags that you should be looking for. Any changes in that pattern, the severity, they're not responding to treatments that worked before. Make sure you're looking into those secondary causes of pregnancy. There is a cool mnemonic for secondary causes of headaches and migraines in pregnancy, and it's a pregnant HA, and you can read what they each stand for, but do make sure you kind of are following up on those and ruling out anything, significant. All right. On to that next one. In terms of treatment, there is really limited high quality data on this, right? Shared decision making is recommended, and how much this is affecting quality of life. The options here are after the patient has already been counseled on like appropriate sleep hygiene, hydration, protein intake, less screen time, decrease their stress, right? Their normal lifestyle changes that we talk about. The top section there, that kind of green blue color, are recommended options by ACOG. The next section, that kind of yellow orange, are suggested treatments that should typically be used with caution, but can be used. And then that red pink area, these are the ones that we do avoid in pregnancy. And these again are coming from ACOG. All right, so you're going to see me refer to this as the big four. And every visit starting in the second trimester, you should really include these four questions. They just kind of roll out as you walk in the door, right? Any vaginal bleeding? Do you feel like you're leaking any fluids? Are you feeling baby move? And are you having any pelvic or abdominal pain? And these are the questions that kind of spawn the follow-up answers that get us thinking. And so usually if you hit these four, you'll get the answers that you'll elicit what you need from the patient. Vaginal bleeding we'll talk about a little bit. Remember, it's predominantly in the first trimester. We will hit on it a little bit for the second trimester. Remember that common time for quickening or feeling baby move is 18 to 22 weeks. However, someone who's had a baby before, they may feel it a little bit sooner. Fetal kick counts, please don't do these too early. They're not going to feel baby consistently really really till the third trimester, but it's kind of a method that's used to quantify fetal movement. And they say you want 10 movements in 2 hours, but the optimal protocol has really not been identified. So it gives patients a guideline to go off of, and you kind of something to help reassure the patient, but it is not set in stone. All right. Moving on to that next one, this is the vaginal bleeding in the second trimester. So, what do you think about if they say yes to that vaginal bleeding question? You don't want to panic. Remember that the majority does occur in the first trimester, not as much. The first three on here are the more benign causes and the ones that you're hoping for. You're really, really hoping it's not preterm labor. But cervicitis, cervical polyp, vaginal lacerations, these are things that happen, and we certainly can take care of those. So moving on to that next slide. On this slide, you start to kind of gather information to see if we need to be thinking about more of a benign cause or more of a serious cause. Excuse me, one sec. So, how much blood? Are they passing clots? Are they passing tissue? How long has it been going on? The exam, are they having tenderness? The pelvic exam with the speculum. Do you see a laceration? Do you see something that makes you think cancer? Are you seeing an abnormal discharge, cervicitis, polyp, fibroids, all of those things? Before you do a digital bimanual exam, do you know where the placenta is? If you do not know where the placenta is located, please don't do the digital exam. We've all been taught this in school. It's just a reminder. Labs you might want to consider getting. Remember that NST stands for a non-stress test. sometimes this is something you may not be doing in your office, but sometimes this is going to be the only way to tell if someone is abrupting, placental abruption, or rupturing their uterus, is on that NST, you will see non-reassuring fetal heart tones. So sometimes we do have to go to the NST, which may involve your OB, labor and delivery unit. If you're concerned, that would be the direction you would need to go. Ultrasound, transabdominal can be enough if you have concerns for like placenta previa, placenta accreta, vasa previa. Then you're going to need transvaginal if you're looking more at the placental insertion. You're probably going to need transvaginal approach for that. The technician will use like pulse color and Doppler to kind of help rule things out. So remember that placental abruption is a clinical diagnosis. You may not actually see a clot or an area of the placental abrupting on ultrasound. So you need to keep it on your radar, even if your ultrasound looks okay. All right, we'll move on to the next one here. So here I just tried to break down for you some of the more common things. You might remember these from school. Vaginal bleeding in the second trimester, you need to think about some of the guidelines that they give, like less than 10 millimeters from the internal cervical os. You don't have to memorize all of that necessarily. Things I want to point out though, like under placenta previa, I put the asterisks. So typically we think bright red vaginal bleeding, painless. About 10 to 20% will have some uterine contractions and pain with it. So sometimes that can throw you off, but just remember that you can see that. So basically, in these patients, you are going to want to give them bleeding precautions, put them on pelvic rest, no heavy lifting. So nothing in the vagina and no heavy lifting until you get it looked at more significantly and you can figure out exactly what's happening. All right, on to the next one. So one of the other questions, remember, was leaking of any fluids. There we go. So there are risk factors for PPROM, PPPROM, which is premature rupture of membranes, but this is not all inclusive. These are probably your more common risk factors for preterm, premature rupture of membranes. And again, it's preterm because it's under term, under 36 weeks. So you have your genital tract infections, your antepartum bleeding can also cause some issues in terms of leaking of fluid, and then tobacco use also increases risk for premature rupture of membranes. The presentation from person to person will vary. It's not always the classic movie star gush. It can be, gosh, I've been changing my underwear 4 or 5 times a day. They just always feel wet. This can certainly be something that's a little less obvious, but take note when the patient maybe says that. Physical exam, sterile speculum to examine the cervix and the vagina, and try to avoid the digital exam if you can. Remember, if they are ruptured, you now have the chance of increasing infection. And so you want to act almost as if they are ruptured while you're trying to figure it out. Okay. All right. So on that speculum exam, what are you looking for? So sometimes you will actually see fluid coming out of the cervical os. Other times you will see a pool of fluid kind of in the posterior fornix. This is obviously called pooling. You can have the patient kind of valsalva or cough, and sometimes you will see fluid expelled through the os. That's also a good indication that they may be leaking. The pH, remember, of amniotic fluid is alkaline, so it will turn bright blue on a nitrazine paper, but this can be affected by contaminants like semen, blood, vaginal infection. So it's not as useful. We don't use it as much as we used to. There are some commercial tests or under laboratory tests that are available. They do require processing in a lab, and sometimes the clinician has to have credentials to actually obtain the test. So you have to be aware of what's out there and what kind of licensing you might need to be doing it, and then what the lab would need to run it. Basically, they're looking at certain proteins within the amniotic fluid. So ultrasound, you may see that the AFI or the fluid index is less than expected if they're leaking large amounts of fluids. If it's just a small amount, they may still have a normal AFI. Gonna bump on to the next one here. Right. So last of the big 4 we talked about was pain in pregnancy, abdominal or pelvic pain in a pregnancy. So these are the more rare causes of abdominal or pelvic pain, but also the ones you don't want to miss. The left side of the screen, typically you see those in the first half of pregnancy. The right side are more common in the second half, so 20 weeks and on. Um, Also important to add to this list, adnexal torsion, uterine rupture, PID. I didn't put them on because they can occur at any time in pregnancy, so they could be in either first or second half of the pregnancy. We'll move on to the next slide. So these are your more common causes of abdominal or pelvic pain. And certainly these are the ones you hope they are. Round ligament pain, that fetal position, where's baby hanging out, baby's movement. Sometimes when they're really busy, it can be quite uncomfortable. Constipation, huge in pregnancy, urinary tract infection, and pyelonephritis. You want to make sure you're looking into those things as well. All right, on to that next slide. So this list is not all encompassing, but these are your non-obstetric causes. Your differential is going to look just like your non-pregnant patient. I just want to point out, remember that some of your landmarks may be different on your physical exam due to the pregnancy. So just remember that when you're doing your abdominal exam. We'll move on to the next one. So this slide pertains to the last question of the big four, which is, are you feeling baby move? We talked about the fact that baby's movement occurs usually earlier in women who have had children versus someone who's nulliparous or has not had children for a lot of situations. If they're complaining, if mom is calling the decreased fetal movement and they call triage, normally, you're going to want to have mom drink something that's cold, a little sugary or a little caffeine, lay down on their left side and start counting movements. And really, the goal is to get them to focus on baby. You don't want them on their phone or anything like that. And if they still are not getting, a lot of time it's the 10 movements in 2 hours, then they need to be evaluated further. And this sometimes requires an NST or an ultrasound for a biophysical profile. Remember, there are things that can cause baby's movement to be low, including a low amount of fluid. If baby doesn't have a large swimming pool, they're not going to move very much. So that's something you want to think about. Fetal position definitely plays into it. Moms who have babies transverse or side to side tend to feel a lot of movement just because baby's really squished in there. An anterior placenta, so the location of the placenta, if the placenta is on the front, anterior, it almost acts like a pillow in between. And those patients will usually complain of feeling movement much later. And they're bothered by it, but it usually is the location of their placenta that does that. All right, let's move on here. So that ends the 4 questions you should ask about at each visit. Let's move on to other important information that should be collected at each of the prenatal visits in the second trimester. So we're talking about weight, blood pressure, urine dipstick for protein. Again, that's give or take, whether it's still being done. And it's being done most places. The question is the value of it in someone who doesn't have hypertension. What's their nutrition like? Any illnesses? And then ultrasound, fetal heart rate we should be getting, and fundal height. So remember, you might see a slight decrease in their blood pressure in the second trimester. Really, it's nothing usually significant, but it's due to that increase in cardiac output. There's a decrease in systemic vascular resistance. All of these things can change their blood pressure a little bit. By this point in the pregnancy, ensure that a dating ultrasound has been completed by now. It's only going to become less accurate the longer you wait. So if they need it, make sure that it's been done by now. Okay. One thing I didn't talk about in the first trimester on ultrasound, sometimes you'll see a subchorionic hemorrhage in the first trimester. And so if you had seen that, the next step is, do you have a follow-up ultrasound that shows resolution at this point? And has the patient had any vaginal bleeding? Okay. All right, we'll go on to the next one. This slide is a review from the first lecture. I want to highlight the important aspects that are needed now that we're in the second trimester. Remember that cell-free DNA can be done at any time in pregnancy, even though patients typically by now they've had it done because they wanted to know the gender, which was the main reason they came, but it really can be done at any time. So yeah, that's probably all I want to point out on that slide. We'll go on to the next one. You guys can read the rest on that. So 18 to 20 weeks, all the same things we want to make sure that we're getting. Now, speaking of fundal height, let's do a refresher on how to remember on how to do this. So remember, under 20 weeks, you are evaluating the fundal height. So you are kind of manipulating the abdomen, feeling for the fundus, making sure you don't feel like it's too large or too low than what you would anticipate based on their period due date. But over 20 weeks, you can actually start physically measuring it. All right. So if you remember, go on to the next slide. Measuring fundal height, you're basically going to go from the pubic bone to the top of the fundus or the top of the uterus. And at 20 weeks, the fundus should be right about the level of the umbilicus. It will then grow approximately 1 centimeter per week. So at 24 weeks, you would expect to be measuring approximately 24 centimeters, etc. This will hold true up until about 36 weeks, so that last month, when it will reach usually about its highest point. And then you may actually see it come down a bit as they get closer to their due date. Baby will shift down in the pelvis a little bit. These are things that we want. Fluid level comes down a little bit towards the end too. So you want to make sure that, it's just those normal changes. Make sure they're not leaking or complaining of leaking of any fluids. There is some variability to this. Obviously, we're not all going to be exactly right on. 2 centimeters is generally accepted range, but that can really vary. Some people will go up to 4 centimeters, which I think is a lot. 2 centimeters, I do start to kind of question, what's mom's hydration status? What is baby's position? What's mom's maternal body structure and body habitus? Like, am I really feeling the fundus? Or, if their BMI is elevated, it's really difficult to get an accurate fundal height with an external measurement. All right, so I'm going to move on to the next thing here. Um, so the fetal anatomy ultrasound routinely is done around 18 to 22 weeks. For some patients, this is the only ultrasound they will have in their whole pregnancy. If you talk to, people who delivered many, many years ago, they're going to say, I had this one or none, So this is the common one if they're going to have it. Looks at routine anatomy. And remember that when you do this one, kind of matters. If they had some abnormal genetic testing, you may want to err closer to the side of 18 weeks so that if you do find something significant going on anatomically, they have a little bit more time to process and come up with an option. If you have a patient who's over their elevated or their ideal BMI, you may push it a little bit closer to the 21 to 22 week mark because it's going to be harder to see everything. So keep that all in mind. This, you can see what this normal routine anatomy ultrasound checks for. Remember that the majority of the babies at this ultrasound will be breech. The patients will worry when they see that or hear that. That is super common. There's still a lot of time for movement. These babies are very active. So if they record it as breech, that's okay. All right, going to move on to the next slide, talking a little bit about cervical length. As we said on the previous slide, cervical length is routinely measured and reported on the anatomy ultrasound, but there are some reasons that you may have wanted to order a cervical length ultrasound earlier than the anatomy scan, like 16 weeks or so. If the patient has, let me back up. If the patient has a term birth since having had a preterm birth, then their risk for recurrence is reduced and you don't need to do it. But if they've had a preterm birth and no further pregnancies, then in this pregnancy, you need to recheck the cervical length. But if they had a preterm and then their next baby was term, you don't necessarily need to recheck cervical length statistically. Okay. Gold standard for measuring cervical length is the transvaginal approach. But remember, on the anatomy scan, they're checking it transabdominally. There's really insufficient data to recommend a specific threshold that would trigger you to then do a transvaginal approach. A lot of it's the patient history. One thing I wanted to point out on this slide, some of you may remember the day when we checked cervical length if a patient had a history of like a cervical leap or a conization, so if they had part of their cervix removed more than just a biopsy, that is no longer recommended in a patient who's asymptomatic and really low risk. So that was a change for me that I had to kind of get used to. All right, moving on to the next one. For the sake of time, I'm not going to do too much on this one. just reading my notes here. I'll touch on vaginal progesterone. So vaginal progesterone has shown to be effective in several studies, including two large multi-center randomized controlled trials, but the data was from outside the US. And so the pregnant trial in the US failed to demonstrate a benefit. And so then the FDA has not yet approved it, vaginal progesterone. So it's off-label, does require patient counseling. There are two vaginal progesterone options that are available and most studied. So far, no data puts one over the other, but remember that you cannot use the micronized progesterone capsules if the patient has a peanut allergy. You have to use the vaginal gel progesterone. And hopefully a pharmacist will help you out with that. And hopefully the peanut allergy will be listed on their meds and it will clock it. But just make sure you remember that one. All right, on to that next slide. Again, we'll kind of breeze through these other than I do want to mention that first orange box. 17-OH, remember, was under the brand name of McKenna, should not be prescribed for treatment of short cervix. This approval was withdrawn in 2023. I can't even remember how many patients we gave McKenna to, and we loved it. But that has been retracted. So that was a change as well. All right, moving on to the next one. So this is 22 to 24 weeks, likely the patient's maybe second or third visit of their second trimester. The big ticket items all still remain the same. These are the things you still need to address. Visits around this time in pregnancy are usually pretty low key. If it's not a patient's first pregnancy, they'll likely have a few questions and then they kind of want to be in and out quickly. These are also the ones where you may find some patients benefit from not having them. And, if they're doing well, maybe they don't need to come for these, okay? This is also the time first-time parents will start to ask a lot more questions. They also start to think about labor and delivery questions, so anticipate that those might start coming up. All right, moving on to the next one, the last visit of the second trimester. The highlight of this time frame is screening for gestational diabetes and anemia. These screenings can be completed right around 24 to 28 weeks, but the recheck of their Rh negative status is typically completed and the RhoGAM is given at 28 weeks. So you'll see a lot of places just do them all together rather than 24 weeks and then more blood work again at 28 weeks. A lot of times you just see them all put together at the 28-week visit. It does go without saying, but remember, you don't need to screen for gestational diabetes in a patient who has pre-gestational diabetes. They're already diabetic. You don't need to do the glucola testing in those patients. All right, moving on here, screening for anemia. Remember, we talked about these pregnancy parameters for H&H in the first trimester. I just moved them over to this presentation. Some clinicians will draw a full CBC. Others will just draw an H&H at 26 to 28 weeks to screen for anemia. All right, next slide. So I want to point out here, screening for gestational diabetes, 1 hour, 50-gram glucose tolerance test is the most common. Abnormal if they are greater than or equal to 130 or 135 or 140. So the definition of abnormal is about as clear as mud. And where I was a student used one, where I worked used another. It's tough. The studies have not shown an optimal cutoff threshold. Clinicians just should determine which cutoff to implement based really on the prevalence of the community risk factors and preference for sensitivity in your lab. But your population. Sometimes you may need to use the lower threshold, but you decide. None of these are going to be considered erroneous. So the 1 hour test is sometimes called the two-step test because if you fail the first part of it, then you go on. If you fail the first part, then you go on to do a 3 hour test. And then in that 3 hour test, which is actually 4 readings because you have a fasting 1 hour, 2 hour, 3 hour. If greater than 2 are abnormal, then they're considered gestational diabetic. There is also a one-step test called the 2 hour 70-gram glucose tolerance. It is diagnostic. You don't have to go on for the next. Thresholds are a little different. Fasting threshold on that is less than or equal to 92. 1 hour is less than or equal to 180. And then 2 hour is less than or equal to 153. If any value is over, then it indicates gestational diabetes. A lot of places try to not do this one as the first step because the patient does have to be fasting. And for the 1 hour, they don't have to be fasting. So if they pass it, then they're good. They move on. It's only if they fail it, do they do the 3-hour fasting. So it's kind of preference, whatever you want to do. All right, let's switch gears a little to gestational hypertension on the next slide here. Remember, this is not chronic hypertension that we discussed in the first trimester presentation. About 16% of pregnant women will develop hypertension during their pregnancy. So that would be considered gestational hypertension. It's almost always made after 20 weeks of gestation for it to be considered gestational. We'll talk a little bit more about preeclampsia in the next lecture, the third presentation, even though it can actually kind of begin in the second trimester. For now, recognize that the main difference between the two is gestational hypertension will present with elevated blood pressures, but you typically will not see lab abnormalities that you see with preeclampsia, and you typically won't see the proteinuria. We'll discuss more about those preeclamptic abnormalities on the next one. All right, so moving forward a little bit here. Remember to think back to those secondary causes of hypertension. Kind of put some of them out here for you. Remember that you tend to see hypokalemia with hyperaldosteronism and that primary hyperaldosterone endocrine disorder section. So just, keep in mind your normal secondary causes of hypertension still need to be evaluated. All right, moving to the next one. So the type and frequency of antenatal testing in patients, and when I say antenatal testing, I typically am referring to like NSTs and biophysical profiles. With non-severe gestational hypertension, it's kind of controversial. I can see these being some of the patients you may be working with on home monitoring, making sure that we're not seeing changes before, having them reporting to a hospital or an OB clinic for non-stress tests. Because a lot of times we will recommend them, once to twice a week. And that can become really, really cumbersome for patients. So a lot of it's going to depend on the severity of their hypertension and their other lab results. Let's see here if I can skip some of this. Yeah, most of it's kind of laid out there for you. So I will just move on to the next one. So this would be more severe. Scenario 2, systolic over 160, diastolic over 110. Manage as you would a patient with preeclampsia with severe features. And we'll talk about those in the third trimester lecture next week. All right, so last slide here, not last slide, last bit of information here, vaccines, live vaccines. Remember, we're not using these. Tdap, late second trimester or third trimester, we do want to offer, obviously you can always offer the influenza and the COVID vaccine when appropriate, seasonally. Those are totally fine. On to the next slide here. Let's talk a little bit about fetal heart rate. Remember that normal baseline for fetal heart rate is 110 to 160. Things that you will see that will cause that heart rate and baby to be elevated, kind of sustained. Mom's side of it, she has fever, infection, she's not been feeling well, medication, stimulants, thyroid conditions, dehydration. You want to ask about all those. If you're seeing, you're listening on the handheld Doppler and you're like, this is beaten up there, at 165, 170, and it's not coming back down. You want to ask about that, including smoking. So did they smoke in the parking lot before they came in? That's going to affect fetal heart rate. And so you just want to be aware of that. And you may need to wait a little bit and recheck it. Okay. Fetal things that can cause tachycardia are listed for you there as well. So you want to keep an eye on those. So accelerations are typically not sustained tachycardia. They are this temporary increase. And you can see these are usually reassuring signs. When you're doing non-stress tests, you actually want to see them. When you're listening with the handheld Doppler, sometimes you can actually hear them. And it's kind of cool to be able to do that. And typically it's called variability, right? So the baby's heart rate is able to come up and come back down. And that variability is a good sign of, reassuring sign, I should say, of oxygenation. We do like that. Bradycardia, there's your common causes listed, both maternal and fetal. You can see this physiologic response can be brief. Babies can be kind of slow, sleepy, not really moving much, depending on time of day, mom's nutrition, things like that. But sometimes it can be caused by like umbilical cord compression. But again, it shouldn't be sustained. If you're seeing this sustained, you do need to think about these more concerning things. All right, so I'm going to change gears here on this next slide. So as we said, in this trimester, patients are starting to feel a bit better. They're less fatigued. They're becoming more comfortable with you as a provider. And so these next three slides are going to talk about topics that patients commonly might ask about that maybe don't seem like a big deal to you, but they can be. In terms of sleeping, the data just isn't there. I typically advise patients to try and not fall asleep on their back. But if they wake up there and they're on their back, just roll over to the one side. I have patients who are like, I stayed awake, so I didn't fall asleep on my back. I'm like, well, could use a little sleep. So just make sure that, they don't stress themselves out about it, especially first time moms. They'll be reading a lot of things on the internet. The data's not there to say that, they cannot be on their back. The idea is as that gravid uterus increases in size and weight, there's going to be more compression on the vena cava, which is going to reduce cardiac output when we're on our back, right? A lot of patients will actually complain of feeling quite short of breath when that happens. And, their body wakes them. And as long as they're not using, medications or things that may be suppressing them, that they don't wake, we don't worry about it too much. Studies don't really support that it increases their risk for stillbirth to be falling asleep on their back. Okay. Do remember if they're on their back, they may also feel short of breath or a little lightheaded. So when you are listening for baby's heart rate, make sure your head of the bed is a little elevated. Sometimes I will have them too flat and for too long if I can't find it. And they can get symptomatic. So just keep that in mind for their comfort. All right. Side sleeping recommended for comfort. There's all sorts of huge pillows out there. It doesn't have to be anything fancy. You can shove some regular old pillows between your knees, keep your hips aligned. That can help too if you're on your side. All right, move on to the next one here. Travel and pregnancy, generally it's safe if it's an uncomplicated pregnancy. The most common time to travel is about 14 to 28 weeks. So this second trimester, energy levels are up, patients are less sick usually. Mobility is still reasonable. They still feel like they can hike a little or walk a little. I do typically recommend that my patients take their pregnancy prenatal records along with them if they're going anywhere. Something happens, I say go to a local hospital. The general act of flying is not really a health concern in an uncomplicated pregnancy. I do recommend that if they are flying, they contact the airline to see when their cutoff is, because some airlines have a really strict cutoff. If you're beyond a certain point, you can't fly. They don't want to take the risk of you going into labor. They have to land the plane. That's money for them. So just check which your particular airline, how far along you can be with traveling. Most patients don't have don't have many issues with it. All right, we'll go on to, I believe, the last one. Obviously, pregnant women are generally excluded from clinical trials and studies. Not really an ethical thing. So, but a lot of women they just want to feel better at this point, and they're talking about, what can I do to my hair? Can I dye my hair? There's most experts recommend waiting until the second trimester. There's not a lot of data on this. What we do have typically comes from hairdressers because they're occupational hazard, being around it all the time, every day. If you're going to do it, recommend going for like highlights or a style that doesn't require the dye to actually touch the scalp, and then elect for like temporary coloring over like those permanent dyes. Do remember, pregnant women are going to be more sensitive to the smells. So be sure that they are in a well-ventilated area as well. All right, I do believe this is the last slide. If you go to the next one. So these topics can occur in the second trimester, but are more common in the third trimester. So I wanted to point them out, but for the sake of time, I did save them for the next lecture. So do know we will touch on these. The next one should just be our next lecture date and time, we're going to cover the third trimester. And then the next slide should be my contact information. And then the last two slides should be the references. And then should have about 10-ish minutes for questions.
We do. So thank you very much for getting through all that, Christina. It's a lot of great information. And being a grandmother of someone who just recently went through a pregnancy, the internet does not do moms or moms to be much good these days as far as
lots of anxiety.
Very much so.
Yeah.
So we're going to open it up to questions. So feel free to come off chat. Come off mute or put your questions in the chat, whichever you prefer. I know there's a lot of information to digest there.
Penny, I'm sorry to hear about your daughter-in-law, and let me tell you, just support her and her partner 100%. Hyperemesis changed my marriage in a good way, but I had a very supportive husband, and I think that it's huge for those relationships to also address what they just went through.
Well, as I shared with you earlier, Christine, I appreciate you sharing that personal story. I'm sure it was
Yeah.
a very difficult experience, but hopefully others can learn from that as well.
Yes.
Yeah. All right. Well, if there aren't any questions, we won't belabor you staying here because you're probably still wanting to maybe grab a bite to eat before you get back to the clinic. Please remember, we will be sending an email that will have the slides and the recording and the information about your ability to get CEs for this session. Our next session, as Christina said, is July 16th at noon. And oddly enough, we'll be going over the third trimester then, which kind of makes sense. So we hope to see all of you back again then, and thank you for joining us today.
Thank you, everybody.
Thank you.